All right, welcome everyone. Thank you all for joining us. My name is Sue Huang. I am the head of data strategy at Datavant, and I'll be your moderator for today's webinar. Today, we have guests from Veradigm joining us to discuss the topic of using fit-for-purpose EHR data to understand health outcomes. Stella Chang is the VP of Life Science Solutions, and Mac Bonafide is the VP of Research Consulting at Veradigm. We will first dive into what data is available in an EHR dataset, then highlight examples of how this data can be used, and finally touch upon some of the insights coming out of Veradigm's participation in the COVID-19 research database effort. If you have questions, you can submit them through the Q&A box in Zoom, and we will answer select questions live at the end of this presentation, time permitting. Stella and Mac, thank you so much for joining us. Can you please introduce yourselves?
Sure. Thank you, Sue. I'm Stella Chang, and I oversee Veradigm's portfolio of life sciences solutions, including clinical research, analytic platform, and real-world data. I come from a background of developing real-world data for researchers, and some of those data sources include public and commercial claims data sets, health risk assessments, disability records, social determinants, and EHRs. And Mac?
Hi, I'm Mac Bonafide. I am the VP of Research Consulting here at Veradigm, which basically means I'm responsible for overseeing and guiding our research activities, ranging from really quick analyses and queries up to full-scale published studies. In many ways, like a lot of you on the webinar, I am an end user and beneficiary of the hard work of Stella and her team in leveraging our data assets for evidence generation. And I would like to start by thanking all of you for attending today's discussion.
Great, thanks for those introductions. Now Stella will provide an overview of Veradigm's offerings to life sciences, and we'll have a live poll to the audience at the end of this section.
Great, thank you, Sue. So Veradigm is an organization that was founded out of Allscripts, the EHR and healthcare technology company. We are a research and analytics shop that offers data, research, and insights to payers and life sciences companies. We leverage the Allscripts network of providers, EHR platforms, and the resultant data to offer the services that you see on the screen. Data is the foundation of our activities. And Veradigm currently offers and utilizes some of the largest ambulatory research data in the industry. The data set that we have available and that our researchers use are extracted from 3 of the 5 largest EHR products in the US. So that includes the Allscripts Pro and TouchWorks product, Practice Fusion, and NextGen. The resultant data product is, something that we call the Health Insights Ambulatory EHR. Okay, and then from these national systems, the Health Insights Ambulatory product captures data, that range from large multi-specialty practices. These primarily come from the Allscripts system, all the way to small practices, which, are generated mostly out of Practice Fusion, and everything in between in that ambulatory setting. So spanning over 10 years, we have records for over 150 million patients in our data set. Some key data elements include diagnoses, symptoms, patient history, so previous diagnoses, previous treatments, lab results, prescriptions, as well as other treatments. I should mention that these data can also be linked to claims and other data sets, but we'll discuss that in more detail in a little bit. So before we dive in, let's just quickly pause for a poll. So the question that we really, want to understand from this audience, and it might also be helpful for you to understand amongst the other attendees for today, is what kind of real-world data are you currently using in your research? You can go ahead and select, and we will show the results shortly.
And it looks like the results are in. So about 60% of people are using medical claims, 50% using pharmacy claims, and also quite a large percent using EHR data. Thank you very much, audience. So Stella, let's dive in to talk more about EHR data, especially its benefits and limitations. Veradigm has the industry's largest commercially available ambulatory EHR data set. And we know that EHR data has unique applications compared to other data types, such as claims. How does Veradigm make its EHR data fit for purpose in answering specific research questions?
Sure, Sue. So let's start by describing EHR data for research, and let's start by walking from the source of the data. So most, if not all of us, have had an encounter with the healthcare system and have witnessed a provider entering information in the EHR. You may recall from your own experience that types of information that are entered in the EHR include the reason for visits, so the symptoms, complaints, any relevant history, vitals such as height, weight, blood pressure, as well as seeing the provider input other information during the visit, like lab orders, pharmacy orders, other diagnoses, and notes. One key characteristic that I want to point out is that those data points are entered as the information presents itself. So it's recorded as you describe a problem, or for example, somebody takes your blood pressure. In addition, feeds like lab results are integrated into this patient record as they become available. What this means is that the data are rarely static, and updates are added to the historical record and sort of accumulate with every new encounter. Let me just also describe, what I mean by an encounter. That could be anything from a full-on inpatient, in-person visit to a virtual or televisit, which are much more common these days, or something as simple as your provider calling in with a prescription refill. Okay, so there are a couple of other key characteristics to note. You may have observed that EHRs are entered through a variety of radio button clicks, drop downs, or just type-free text notes. So all of these actions will have implications on how robust and usable certain data elements are in the EHR. But generally, I'd say that EHR data is very timely and dynamic. This does not necessarily mean the data is available in real time, but even with the cleansing and de-identification steps that are taken to make the data research ready, the data are as often as current as a month old or a week old. Okay, so I'd like to highlight some benefits and limitations of EHR data. Unlike the most common and available source of real-world data, which are claims, EHRs capture data for all patients, regardless of their health insurance or whether or not they have insurance at all. While EHRs leverage standard coding systems, they usually have the capability to capture more types, such as ICDs as well as no-med codes, than claims. What this means is that there's the capability to capture patient data in more granularity. Sometimes certain conditions are better described in one coding system versus the other. But it also means that the provider has options and a preference on how they record something, and the analyst needs to understand how broadly to search for something in the data. As I mentioned, EHRs have the capability to capture visits, have to derive or divine from claims, or take the time and effort to survey and collect directly. There are other information that we would have to interpret and assume from patterns and claims data that are readily available in EHRs. These can include whether a particular intervention was introduced, and sometimes we also have information as to why. We can also tell consistently the diagnosis behind a prescription. Another key piece of information that's available from an EHR is the use of over-the-counter drugs. So as with any source of real-world data, there are limitations when EHR data are applied to research. So until we have true interoperability, and that interoperability translates into data use rights, we're still confined often to a single setting view of the EHR data. You're seeing really, you're seeing information where it's collected. When it comes to prescription drugs, specifically those that are not administered in the office, the EHR is reporting the prescription. It's not intended to be a receipt of the actual fill. So subsequent records may offer information on whether or not a patient was compliant with their prescribed treatment. But again, this is a difference between an EHR and looking at, drug claim fees. EHRs are also first and foremost designed to support the provider-patient interaction. This means that the system of capture is very customizable to the provider's preferences, and the provider has a lot more leeway in how they complete an EHR and use a particular coding system. Data like procedures and billings are critical for payment, but how they are recorded or not in an EHR is very different. Again, that's because the primary purpose of an EHR is to maintain a dynamic and longitudinal record of the patient's health, and it's not necessary or relevant always to record every single thing that was done to the patient during the visit. And while we've talked about the clinical detail that's captured in the EHR, it's important to note that not all the data are easily accessible and queryable. So this includes information that is recorded only in provider notes. It could also include attached PDFs from labs and other providers, as well as imaging. So the strengths and limitations that I outline mean that, like any others, like other sources of EHRs and real-world data, one must evaluate fit for use and fit for a particular research project. This isn't a one-size-fits-all, and the researcher needs to consider whether the research question and the path leading to the answer for that question can be built from EHR data. But generally, what you're seeing on this slide are what we consider to be the best uses of EHR data in research. Okay. So EHRs tend to vary from source to source, much more than some other types of RWD. And while the first step is to determine whether EHR at all is a good fit for a study, the next is to find among available EHR data, is there a source that will meet the study's needs? So here's some considerations when you're evaluating the fit of a specific EHR source of data. One of the first questions I would ask is, what kinds of providers contributed records to this source? For example, are you looking at records that came from large hospital systems or academic medical centers, or are they coming from small rural practices? And once you've determined this, then you can start thinking about, well, given the source, what kinds of data would be missing from these sources? And also, who are these, who is rendering the treatment and recording the data, and who is the recipient of the treatment and having data recorded? Are you looking at a population of providers that are generalizable, and the same with the patients that they are treating? And then particularly for hospital EHRs, it's important to consider that data capture may be for a finite period around an episode. For example, there have been a lot of publications and great insight about COVID from hospital EHRs. We started seeing some of these reports as early as March and April of this year, and they've helped us understand what the severe cases of COVID-19 look like, and also the efficacy of treatments like remdesivir. However, it will be a challenge to understand the long-term effects of COVID-19 after patients are discharged and managed in the ambulatory setting. Now, one way to address this, would be looking at EHR, looking at health systems who are capturing inpatient and outpatient experiences and data in an integrated EHR system. Some examples of these systems and health systems include Kaiser and MedStar. However, they tend to be limited to a particular geography. And then, the last point that I will make here is that, when considering EHR data, you do need to make sure you understand what is and isn't available in standard queryable fields. So, again, keep in mind that an EHR could have a drop-down or a radio button, but a provider may choose to still just put everything down in notes. So it's not uncommon to take additional steps to supplement the EHR data that is readily available. This can be done either with natural language processing or AI, or with linkage to other RWD sources. So let's briefly touch on natural language processing. As I mentioned earlier, a great amount of patient detail can be recorded in the notes, but it's not realistic to view years worth of notes for thousands of patients. And there's also the consideration of notes are not easily de-identified. But this does not mean that these data are never accessible to research. There's been a lot of attention to natural language processing and artificial intelligence. While there's no question that we've made incredible progress in recent years, it is still an emerging field. So what I'd like to do is share a little bit of what we've done at Veradigm to make sure that we can get at some of this rich data and make it available to other researchers. So I have two examples here, and let me first state that so while physician notes can be de-identified, there are a lot of trade-offs when it's conducted at a broad scale in terms of what data must be removed, redacted. And then one must also consider that the identification alone doesn't solve the problem of you still have hundreds of pages of text to consume for each patient. So Veradigm, we were taking a different approach. So, let me first state that we do have rights and access to certain EHRs from certain providers to access the notes. From there, we can apply NLP to extract key clinical data and concepts that we populate back into the standardized fields. And it's also important to note that we do this just for the research data set. So what we do not do is repopulate the actual EHR. After all, the provider chose to record that data in notes and not in an already standardized field. We also chose to develop and point our NLP solutions towards fields for specific conditions. So I have two here where we looked at bone mineral density scores for osteoporosis, or and we looked at HbA1c results for diabetes. What we found was that using this targeted approach, we are able to get a higher yield of data and also more accurate data. So in other words, we don't try to boil the ocean and get everything we possibly can from the notes. So here's another example of the application of natural language processing to our EHRs, and this one is for atopic dermatitis. When, even though coded diagnoses exist, this is a condition where provider observations often go right into the notes. And, as you can see from this table, our analysis showed that reviewing transcripts for key terms, in the right context, almost doubled the number of patients who met our study criteria. So that was just a very, very quick overview of of what we're doing with NLP, and certainly we can do much deeper dives into this. But let me spend a few minutes talking about the other way that we sort of enhance the value and the applicability of the EHR data, and that's through linkages. Because even though NLP can add to additional can add additional information about a patient, the EHR still only captures what it captures. And this is where linkage to other sources offer a more comprehensive view of the patient. So linking EHR and claims data have some obvious benefits, but they also have some clear drawbacks. On one hand, there are additional insights gained, including information about prescriptions written versus filled, the severity and nuances of diagnoses from that you can gain from documented symptoms and deeper coding systems. as well as the opportunity to evaluate financial alongside with clinical data. On the other hand, you should also think about the data lag that is driven by the slowest data, set of data elements, in this case, claims, and also consider a loss of sample size because you're looking at an overlapping population. We can dive much deeper into this, but for now, let's touch briefly on the mechanics of linkage. Okay. So with real-world data, we're usually looking at data that's de-identified, and this is a really important consideration, with linkage. De-identification means that data can be much more broadly shared to researchers. It also addresses some of the challenges and barriers to tracing data back to the patient and obtaining consent. It's important to note that even de-identified, each RWD source still comes with a set of conditions and restrictions for use. It's also important to note that if de-identified, data cannot be easily matched back to the same patient. While the sources of data, such as an EHR system or a payer, may have patient identifiers for matching, these sources cannot share these identifiers with each other. So the steps that I outlined on this slide describe generally how this matching can be done efficiently and without exchange of patient identifiers. However, I'm going to take a pause here and ask Sue to jump in and describe the Datavant process as a real example.
Sure, thanks, Stella. So Datavant's software platform allows organizations to de-identify and link records for the same patient. And how we do that is software can be deployed on-premise behind an organization's firewalls, and the software creates unique keys for linking data at the patient level. As Stella mentioned, this provides a more comprehensive longitudinal view of the patient. So in this example that I'm showing on this slide here, using myself as an example, if you were interested in understanding my outcomes after I switched to a new diabetes medication, you could link together my EHR data from an outpatient endocrinology office that I visited with inpatient EHR data from my emergency department admission, for instance. And you would know that both of those correspond to the same person through the ability to link those de-identified records together using the Datavant patient key, but you wouldn't know that those records correspond to Sue Huang specifically, therefore protecting my privacy. So our software does this by applying a unique encryption key for each organization to create patient keys that are built from identifying information that each organization may have for me, but it does not, it encrypts the identifying information in a way that you don't know the record is for Sue Huang. And it's not until the point of linking data between two organizations that Datavant software will transform those keys so that they actually become linkable. And this is a unique part of Datavant's overall software security infrastructure. So this kind of data linkage across disparate sites of care in our fragmented healthcare system is only as powerful as the size of the network itself. Our software is deployed across hundreds of sites to enable our partners like Veradigm to connect to the nation's largest ecosystem of real-world data. And we cover a broad spectrum of data types, from EHR data like at Veradigm to organizations that have claims data, laboratories, specialty pharmacies, and academic medical centers use our software as well. And in addition, we're growing into more non-traditional healthcare data sources such as social determinants of health data. So now we'll pose another question to the audience around data linking. What kind of data would you be interested in linking with ambulatory EHR data? Please select an option from the screen. Okay, the results are in. Looks like they're the top two data types that folks are interested in linking to the EHR data is claims, medical claims, and pharmacy claims data, with lab data following at a close third. And a lot of people also want to link all of the above. So a lot of interest in linking from this audience, which is great to see. Thanks, everyone. So now we'll move into a discussion oriented around use cases for EHR data. As we've heard so far, EHR data provides a depth of clinical richness to understanding a patient's encounters with the medical system, and often on a much shorter time lag than other healthcare data types. Mac, would you be able to provide some examples of the use cases that Veradigm data can power?
Yes, thank you. For the next few minutes, I'm going to cover basically three main topics. First, I'll highlight a few case studies on research insights gained from our EHR data where we needed kind of a greater clinical depth than we could get from claims data alone or a lab database alone. I want to start off with a very big caveat. I'm going to spend a minute or maybe two at most on studies that quite literally, spanned hundreds of labor hours. So I apologize in advance to the research teams behind those studies that I'm going to grossly oversimplify their efforts. After that, I'm going to build on some of the stuff that Stella described and discuss a couple examples highlighting the value of linked EHR data. So specifically where we get elements from both and kind of touch on the pros and cons of that approach. And then I'm going to close out by presenting some real-world queries we've been doing on our EHR data around COVID-19, including closing out with a brief discussion of the COVID-19 research database being led by Datavant and highlighting some ongoing approved studies using our data to explore the relationship between different treatments for diabetes and changes in patient weight and or HbA1c. So these are two elements that are obviously not found in most administrative databases, but as you can imagine, are routinely collected in a clinical setting. So the graph here depicts changes in HbA1c, both unadjusted and adjusted. And the reason I point this out is it's noteworthy that the database had sufficient patient data. So other characteristics besides just the HbA1c or just the weight and just the treatment that allowed us to run adjusted analyses in a way that they meaningfully changed how we interpreted the results. Obviously, those two bars aren't kind of spot on top of each other there. And again, in the same study, we looked at changes in patient weight, again, unadjusted and adjusted. And the point here is not to read too far into which treatment had the best outcomes, but to point out that the database had enough deep clinical information to answer these questions and then show differences and then engage in a healthy debate over what you do and don't control for based on other characteristics in the database. Next, I'm going to quickly talk about a couple studies where we needed the clinical depth of the EHR, but we also needed to show some kind of real world impact in the terms we're used to talking about. So we recently did a study where we looked at the impact of albuminuria on different outcomes in patients with type 2 diabetes. In this case, we are starting the presence of albuminuria counts were an integral part not only of patient selection, so you had to have a valid score to get into the study, but then that was your study cohort for the life of the study. So it was getting in and then getting classified. And not surprisingly, qualitatively not surprisingly, we did find that there were increased symptoms and comorbid conditions and outcomes associated with macro or micro levels versus folks with normal albuminuria. You can see it on the graph here: anemia, ASCVD, CAD, CHF, whole litany of outcomes and comorbid conditions where the macro patients fared the worst, followed by the micro patients and the patients at the normal level faring the best. We then incorporated administrative claims data to see if there was a relationship between, macro, micro, and normal and healthcare resource utilization. And we did find a relationship. Again, this is not surprising based on the prior one, both in terms of heart failure hospitalization and all-cause hospitalization. So again, patients with the normal levels fared the best, but this allows us to then control for those two different moving parts in predicting what drives utilization, what drives worse outcomes. So in my last non-COVID example, we again combined the clinical depth of the EHR, where we looked at blood eosinophil counts and their impact on healthcare resource utilization and costs among patients with COPD. Again, full caveat, this is just a fraction of our full study results, but you can see a snapshot showing higher adjusted costs, both all-cause and COPD related, with increasing blood counts. And one luxury of having direct access to the data is we can control and evaluate different data formats. So in this case, we implemented it both as a continuous measure, but also as a dichotomous measure to see where the cut point for the meaningful change in healthcare resource utilization and costs was. So I'm going to spend the remainder of my time talking about what is front and center on all of our minds right now, which is providing a high-level overview of some queries and analysis we've been running internally around COVID-19. So needless to say, like the rest of the world's thinking, our thinking and approach to these has evolved since we started doing them back in March. Some of these were based on really simple questions we were hearing from our practices, like, hey, we're seeing this, we're seeing that, we're seeing really high use of this, we're seeing really low use of that. Are other practices reporting this? Are you guys seeing this in the data? How can you help us understand what's happening in our practices right now? We're getting that from obviously healthcare practices, networks, and facilities. We're also getting it from public health officials, government officials, and just like you, basically everybody we talk to on a daily basis, whether it's our parents, our friends, our coworkers, the mailman, everybody. So we started a bunch of queries to help kind of tackle this. So very early on, we started a really simple approach, which was just a dashboard that shows us the most common medications being used in our practices among patients with either positive COVID test result and or diagnosis. And those two things don't always line up perfectly. So we kind of kept them as different categories as we built this out. We use this to immediately help triage questions around different potential treatment options or management strategies for COVID-19. So we could help analysts determine which medications had adequate sample size, which ones should we look at first. At one point we were refreshing this weekly so we could see changes over time to see when a sample size got to a point that was warranted further investigation. An early research question from a number of sources was around hydroxychloroquine and azithromycin. And I smile because this was my favorite graph because, obviously there's a lot of media attention around this. We kind of as an ad hoc wanted to see how that media attention was translating in our data in terms of real utilization. Was it having an impact? And we qualitatively expected to see something like this. But I would say we were all pretty shocked when we actually saw the real numbers that came through. So this is a year-over-year comparison. We're comparing 2020 to 2019. March 2020 utilization of hydroxychloroquine and azithromycin was 4 times higher than March 2019. April 2020 was 5 times higher than April 2019. Relatively speaking, things did settle down a little bit in May and June. They were only about double for 2020 versus 2019, and they kicked back up to a 4-fold increase in July of 2020 versus 2019. Now, we started off back in March running this as a joint hydroxychloroquine azithromycin analysis. We've since confirmed that it is actually hydroxychloroquine that is driving this change, and that azithromycin use is much, much more stable. So specifically around this query, in addition to looking at the year-over-year results where we aggregate at the month level, we wanted to look at things day by day. There were some really noteworthy media events that had a very distinct point in time. We wanted to see what was the impact of those events, what was the impact of those mentions. So we plotted these things day by day. And again, this corresponds to what we saw in the prior graph. This is exactly what we expected to see, but the peaks were still surprising. And obviously we're still building this out over time. We'll add August pretty soon. One important side note is those little valleys are the weekends, and you see they go down close to zero, but not entirely to zero, as we do have some practices that are obviously open and functioning on the weekends. So somewhat refreshingly, and frankly a little bit unexpected as well, is that throughout this time period from January to July, we actually saw very little change in the use of first-line antidepressants. So the full list of agents is listed below in the sub-bullet. I'm not going to read them or even try to pronounce most of those. Obviously 2020 is tracking below 2019, particularly in April and May, but frankly, we were expecting far worse. And frankly, we're relieved to see that utilization has somewhat stabilized in June and July. I know, like all the other EHR companies, our support teams have put a ton of time and effort into getting our practices on board with telehealth capabilities. I know we've processed over 1 million telehealth visits since the start of the pandemic, and this might be partially driving why some of the utilization here was able to stabilize so quickly following those drops in April and May. Another product that we really like to keep an eye on going forward is dexamethasone. So initial results of the pandemic show obviously substantially lower use in 2020 and 2019. So if you look, tracking nicely very evenly in January and February, March it starts to drop, and April and May the bottom just drops out on dexamethasone use. It has started to creep back up in June and July, and the reason we're keeping an eye on this is a lot of ongoing research and discussion around dexamethasone. Certainly not as much discussion or publicity as hydroxychloroquine. It's not so much what are the results of these analyses, but does the attention or perception of it change utilization? So we like to track this one out going forward to see if we see a hydroxychloroquine-like spike in its use based on some of those discussions. And lest you think all the utilization do exactly as we expect and plan, we have famotidine. So interestingly, for famotidine, we're seeing use across the board as higher for all of 2020 compared to 2019, but this started before the pandemic. I know famotidine got a lot of publicity early on as a potential agent that could help manage or prevent COVID-19. But this utilization, all of 2020 month over month is about double what we were seeing in 2019. Again, not entirely expected, and something we certainly need to dig into in the coming months as this discussion and as the clinical research around it starts to catch up. And here's just a real quick snapshot of some kind of key utilization changes we are seeing in our EHR. Obviously we're seeing a massive uptick in utilization of masks and gloves and those types of PPE. We're also seeing a big uptick year over year. Again, this is July 2020 versus July 2019. Increase in DNRIs and vitamin supplements, specifically, zinc, vitamin A, D, and C. It's noteworthy that we've heard about the fertility bust period or reproductive bust period right now. We're seeing a decrease in utilization of family planning agents, a big decrease from July to July. It'll be interesting to see how long it takes for those things to stabilize back to 2019 levels. We've got about a dozen or so different types of utilization that we're tracking, that we'll continue to track over time and find up the right venue to kind of report them out kind of comprehensively. So here's an example I'd like to spend a little more time on. So in a separate work stream, Veradigm is participating in a coalition of data partners who are running a series of federated and coordinated analyses to help address key questions throughout the pandemic. So this particular coalition is being led by MITRE Health, and this analysis included members from Athena Health, Cerner, Epic, and Health Catalyst. So, and MITRE Health presented these results and a few other volunteer-driven analyses in a webinar a couple weeks ago. You can find it on our website. The link is shown here. I strongly suggest you take a look at it. It'll be well worth your time. It's really top quality researchers pitching in here to answer some important questions. So the analysis here, we started this back in March and started running the first numbers back in April. We were trying to evaluate potential reinfection, or rather indicators of potential reinfection. Remember, we didn't know a lot of this stuff back in April. We started this analysis by looking at what was the distribution between two positive PCR results. So if a patient had two or more positive PCRs, how far apart were they? Really simple question. The reason this is important is if we start to see a bimodal distribution, that would suggest possible reinfection. Instead, we are seeing exactly what we had hoped to see, which is that the means and medians are right around 2 weeks. And it's important to note that, way out at the tail, the high max values does not suggest reinfection. At this point, we don't even know if those patients are contagious. We don't know if they're still having symptoms or shedding virus. This is patients who had a second PCR way out there in the tails of the distribution. We obviously are going to keep refreshing this analysis and pooling the data along with the other members of the coalition to see how this changes, and always be mindful and keeping an eye out for potential kind of bimodal distribution or a second bump. In doing this and contributing to this coalition, we've been running a whole bunch of analyses related to this on our own. And one of those things is some very simple summary statistics about the mean and median time in our data between the two positive PCR results. So if you look back in April, it was about a 10-day mean and median. But again, it's April, so you don't have much follow-up time. When we refresh it in May, June, pretty much by May, it stabilized exactly where we expected and hoped to see it, which is mean and medians around 2 weeks. And you've got, obviously, range gets longer as you have higher max values with longer follow-up. This is something we'll kind of keep running on our own and keep contributing to the coalition. So with kind of more recent iterations of this analysis, we've started to explore symptoms, COVID-19 symptoms associated with both the initial and subsequent positive PCRs. Now, I'm not going to read through this entirely, but I do want to point out kind of two interesting trends. First, if you look kind of from left to right across the chart here, there's been a shift in diagnoses among patients with a positive PCR as we've expanded testing. So in March, 25% of PCR patients had fever, but that cumulative percent was down to 15% by July. This represents like a massive shift away from people presenting with fever. Likewise, the presence of cough decreased from 28% in March down to about 20% in July. And other symptoms, which is a broad bucket, includes anything that the CDC says might be a symptom, has increased over time, but so has the percent of patients with a positive PCR with no common diagnosis. So this suggests we're getting a massive increase in a proportion of patients that are asymptomatic but testing positive. So that's one key finding. The other one is that there's been an increase in the percent of patients with a COVID diagnosis in the chart prior to having a positive PCR result. And this is something we need to untangle, right? Because again, this is only among patients with a positive PCR, but this could suggest that physicians are entering a COVID diagnosis based just on the clinical presentation while they wait for lab confirmation, or it could represent a lag in the data values. Either way, it's something we need to untangle as we start to keep a lookout for that second bump. So the last item I'd like to cover, and something we're really excited about here at Veradigm, is to talk about the COVID-19 research database that is being led by Datavant. So starting back in April, Veradigm started reviewing research proposals from government, academic, and other similar organizations about answering timely questions about COVID-19 using Veradigm's research assets free of charge. So this is a pro bono effort. We review the proposals, we answer questions, and we provide the data and support for free. This is the same clinically rich data that you'd get through a commercial license, but the use is obviously limited to the proposed and approved research question. The reason we're excited about this is just to state the obvious. There is no shortage of vital research questions around COVID-19. This program is intended to get the necessary data into the right hands to start answering these questions for the good of public health. We do know that several organizations like Veradigm are contributing to this, and we really thank Datavant for pulling us together into this important public health effort. And here are a few of the approved research projects. I want to go through and read them each because as much to say thank you to the researchers for taking on this work, but to give you guys a heads up to keep an eye out for the results when they come out. We have the impact of COVID-19 on prenatal and postpartum care coming out of Harvard. We have transcriptomics-based computational drug repositioning for COVID-19 coming out of UCSF. We have a high-impact study evaluating changes in service use and outcomes for postpartum women and their infants before and after COVID-19 at the Urban Institute. And then we have Hopkins and Stanford contributing to a retrospective analysis of drugs to treat COVID. I think you'll all agree these are important public health questions that somebody needs to answer, so we're happy to be a part of the group that gets to facilitate those questions getting answered. And just to close out my section, I'd like to have a quick sincere thank you to some of my colleagues who made this presentation possible. So Nam and Jordan, I just get to talk about it. They did all the heavy lifting and actually getting the numbers in front of you today. And then Lee and Natalia were key members of our COVID research database protocol review team.
Thank you so much, Mac, for that really interesting look into some of the insights coming out of Veradigm's research data set. So that concludes our prepared content, and we have about 15 minutes now to take Q&A. To submit a question, you can click on the Q&A icon at the bottom right of the Zoom box. And we do have some questions that came in during the presentation. So let's start with one that inquires about the medical focus areas of the Veradigm data set, and there's particular interest in whether there's oncology coverage.
So I'll take this one. So sort of going back to some of my points made earlier, as you're interrogating a EHR record source for research, you really need to think about who uses those EHRs, what kind of practices. So the EHRs that are feeding into our Health Insights ambulatory are, like I said earlier, Allscripts, Pro and TouchWorks, Practice Fusion, and NextGen. So these tend to be used in office-based practices. And, I would say pretty broadly for that. But having said that, and specific to oncology, oncology tends to be an area where there are specialized EHR products. So with Veradigm and what we have available in the data, it's really more around primary care and specialties that are not oncology focused. That doesn't mean that we do not have records for cancer patients, but usually when they go to, once they go into sort of more specialized and targeted treatment, that flows into a different EHR system.
Okay, thank you very much, Stella. Another question we've received is, can you describe what interoperability means in the context of EHR?
Sure. So in the context of EHR, I guess, at the most basic, what I was thinking about when I made that point about interoperability is just, the EHR, all the EHRs talking to each other. And, sort of behind that would be that providers have easy access to information that was collected in another provider's EHR. So that's one component, when you're thinking about how comprehensively can we have data for a particular patient. But that's only half the equation. The other component from a data availability standpoint is, do we have rights to have that data and use that data from all of these settings of care? So if we have, we have ambulatory data and maybe there is a connection to a hospital EHR system, then that's wonderful from a patient management perspective. From a research perspective, we still need to have, the rights to access both of those and put them together for the same patient.
Okay, great, thank you.
Mm-hmm.
And then there's a series of questions around more about the data set itself. There's a question around whether you have information about number of physicians and practices that are roughly covered, as well as coverage from academic centers or community hospitals.
So for the purposes of this webinar, I will just answer with yes. And we're happy to follow up with whoever is asking, as well as any other audience members who would like to understand the more detailed information and the distribution.
Okay, great. Is there anything you can share about how frequently the data is available, typically from Veradigm's data set, and any sort of data lag?
Sure. So we're speaking about the EHR data itself. We refresh on a monthly basis for 2 of our 3 systems. That translates to about a 1-month lag, and then for the third one, it is, it's currently on a 2-month lag, and we're working on that. But certainly to my earlier point, as soon as you link that to another data source, then you need to also look at that other source and determine if that sort of pushes you back in time because of the time because of time for data collection, adjudication, and creating the product.
Okay, next question is anyone collecting and analyzing genomic, cardiometabolic, and COVID-19 acuity or severity data that you're aware of?
I would say lots of, that there are several firms and government agencies who are collecting that information. I can't really speak for them, but I would say for us currently, we, as an Allscripts company, we do have products that collect genomic information. We are not currently integrating that into our de-identified data set. So, so access would come through other channels and, through really research and analyses on our end. And I'm sorry, Sue, what were the other sources?
Cardiometabolic, and then anyone doing studies on COVID-19 acuity or severity of
Sure.
COVID-19.
Sure. So in terms of cardiometabolic, I would say that, that is an area where our EHR data are already rich. We do have a, large number of cardiology practices, endocrinology, not to mention that a lot of treatment for these conditions and their sort of co-occurring, symptoms are treated in primary care and with other specialties. So we've done a lot of work, and our users have done a lot of work in those areas. In addition to that, Veradigm, we didn't talk about this today, but we also operate a national cardiology registry called Pinnacle, as well as a national diabetes registry called the Diabetes Collaborative Registry. These were historically run by the American College of Cardiology, and since last summer, we've entered into a partnership to support these registries and make them available for researchers. In terms of COVID-19 acuity and severity, I think that is still very much an emerging field. We're all learning as we go along, as Mac has said. I would say that EHR data, not just ours, but also from other EHR sources, were among the first sources of real-world data that was available about COVID. And again, that goes to how quickly the data gets entered and is accessible, and also just how comprehensive that is in terms of capturing symptoms. Because early on, if you think about it, we didn't know exactly what COVID-19 was, and we're still learning. In terms of, are there specific registries that are being set up for that? I don't know of any that's available at a national level. That's not, and I'm talking about like patient level registries at this point. What I have seen come up very quickly, and we're continuing to see, is really the assembling of COVID-19 specific research data sets from a variety of other real world sources, and I think that that will continue.
Okay, thank you very much.
Mm-hmm.
Now there's a question around the level of granularity, whether it's 5-digit, 3-digit zip, census tract that you have on a patient's location, and whether you would typically make that linkable to other geolocation-based SDOH data.
Mm-hmm. I'm going to answer that in a way that is not very satisfying. In that my answer is it depends. So, and I'll explain why though. So, on our de-identified EHR data, we are required to keep patient location at a 3-digit zip. And anything more granular than that has been determined to be a re-identification risk above an acceptable threshold. When it comes to SDOH, that's a really, really broad category. Whether or not we can, and I guess let me just back up and say also the linkage of that is can happen a variety of ways. Everything from a direct patient linkage, which is optimal, to injecting some social determinant variables based off of geography. For example, a census block. So in terms of what can we make available to researchers that have the clinical data as well as SDOH, it really comes down to the result. And usually when there's a linkage that's been done for the first time, what we need is to make some adjustments so that the patient information, the patient identity can still be protected. The easy way to do that would be to take like a safe harbor approach and say, this is a list of 15 variables. You have to get rid of these. However, that is really restrictive, in terms of a lot of the research that, we all want to do. So then you kind of move into this another area called expert determination or statistically the identification, in which case it becomes very customized to that combination of data that's coming together. But the other part of customization is understanding what the research goals are and understanding, what the give and take is so that you can still answer your research questions.
Okay, thank you.
Mhm.
Another question is, how well are the social determinants of health variables captured in the data set?
So we actually did look into that, and we do have a white paper about that. And again, we're happy to follow up with whoever asked this question, or if anybody else in this webinar is interested. So one of the things that we looked at, and we always start here when we're looking at EHR data, any real world data, is there, what's the low hanging fruit? Is there something that's already coded and well used? And do we start with that? And so what we started looking at in that regard was with ICD-10 coding, because there are many variables, and we did find that it's being populated, but really not at the degree that everybody would like to see. So then I think the next step then is to look through the notes, and again, that's where we would have the application of NLP technology and really understand, like I said earlier, social determinants is such a broad category. Is we would sort of turn that to what are we looking at specifically? Is it is it housing? Is it education income? Is it food insecurity? There are a number of there are a number of questions there. So I would say, if you're looking for something that's readily available in EHR data, it's probably not at the level that we would like. But are there other ways to get at that? The answer would be yes. One is notes, and then the other would be, again, there are other data sources for social determinants, and there again we get into the question of what can we link, what do we get to keep, and what needs to go away when we do that link.
Yeah, and there are a number, just to add on to that, Datavant works with a number of providers of social determinants of health data, and we can work with a partner like Veradigm to think about how do we link that together in a compliant and privacy preserving way. So we can certainly follow up with the asker of that question on that. Okay, I think we're going to conclude here. Thank you everyone for joining today, and thank you so much to our guests Stella Chang and Mac Bonafide from Veradigm for sharing your insights. If we didn't get to your question today, we'll be following up with you separately, and we have recorded this webinar, and we'll make that recording available in the next week, and we'll send out an email to everyone once that's available. Thank you. Any closing comments from Stella and Mac?
I would just say thank you to Datavant, and also for our audience for giving us your time and listening to us. Thank you.
Yes, thank you to all you folks, and also thank you to the researchers who are tackling some really good public health questions using the research database. Thank you all.
Thanks everyone. Have a good rest of your day. Bye.
Thank you.
Bye.
Stay safe.